Good afternoon, ladies and gentlemen. Today I'll talk about type 2 diabetes and kidney disease. What evidence do we have? Unfortunately, as you know, that diabetes is increasing globally, and it has been estimated that 40% or more of people with diabetes, they will develop CKD, including a significant number which would develop kidney failure requiring dialysis and renal transplant. So glycemic control and residual incidence of CKD, once HbA1c is higher, the risk of CKD is higher as well. And of course, microalbuminuria will increase. So cardiovascular mortality risk increases with progression of CKD, and you can see here in microalbuminuria group, the incidence or the relative risk of cardiovascular death is higher in comparison to the group with microalbuminuria and normal albumin-creatinine ratio. Presence of both diabetes and CKD poses the high risk of cardiovascular event, whether congestive heart failure, acute MI, cardiovascular event, TIA, peripheral vascular disease, atherosclerotic cardiovascular disease, and death. The risk is higher in all these groups in the patients who have diabetes and CKD. Now, renal benefits of SGLT2 inhibitors. I'm sure you know about SGLT2 inhibitors. It has been available in the market for a long time. Just to summarize the effect of SGLT2 inhibitors, it will reduce plasma volume reflected by increasing in hematocrit and hemoglobin, cardiac remodeling because there is a modest reduction in left ventricular and left atrial volume and left atrial mass. This will lead to reduction in epicardial fat, improved myocardial energetics under the condition of mild hyperketonemia. The heart may metabolize beta-hydroxybutyrate, preferred in preference of fatty acids, inhibition of the lead component of the cardiac sodium channel current. There is reduction, of blood sugar, hypoglycemia, low risk of hypoglycemia, diuresis, and reduction in blood pressure. But of course, it's not a treatment of hypertension, but there will be a reduction of blood pressure. Factors other than natriuresis and volume changes may contribute to the blood pressure lowering effects. There is a body weight-driven reduction in body weight, and this is because of the fluid reduction and because of excretion of the glucose will lead to reduced calories. There is a reduction in intraglomerular pressure and reduction in albuminuria. So all these things will lead to reduce in cardiac overload or workload, reduction in atrial stiffness and vascular resistance, reduce hyperfiltration, and the end result of this will lead to reduction in the risk of kidney outcomes. EMBARC trial focus on kidney outcomes. I'm sure you all know about, or at least you've heard about EMBARC trial, which is one of the largest cardiovascular trial. The aim of the trial was to examine the long-term effect of empagliflozin versus placebo on top of standard of care on cardiovascular morbidity and mortality. So they have divided the patient into 3 groups. One received a placebo with plus standard of care. The others received empagliflozin 10 milligram and empagliflozin 25 milligram, and they followed these patients for 2.56 or 3 years. The kidney outcome, you can see here the rate. In the empagliflozin group, the incidence of worsening nephropathy was 12.7%, whereas in placebo it was 18.8%. Progression to macroalbuminuria in empagliflozin group was 11.2%, whereas with the placebo 16.2%. Doubling of serum creatinine, 1.5, whereas with 5.5, whereas with placebo it was 9.7. And initiation of renal replacement therapy, no comparison between, of course, the 2 groups. So all the results were in favor of empagliflozin. Significant reduction in relevant renal events with Jardiance. So with Jardiance, the progression to macroalbuminuria was, the relative risk reduction was 38%, doubling of serum creatinine by 44%, initiation of kidney replacement therapy by 55%. So kidney outcome according to baseline eGFR and urine albumin creatinine ratio categories. Whether your patient GFR is less than 45 or between 45 or less than 60, between 60 to less than 90 or above 90, in all the result was in favor of empagliflozin group, even with urine albumin creatinine ratio whether less than 30 or more than 30 milligram. So all the results showed that there is reduction in the risk of incident or worsening nephropathy was consistent across baseline eGFR and across urine albumin creatinine ratio categories. Empiric mean adjusted eGFR over time, so empagliflozin slowed eGFR decline over time. So regardless of whether you start from the beginning or from here you can see in comparison to placebo, this will slow the decline of GFR in patients with diabetes. So Jardiance maintained kidney function and reduced the risk of nephropathy. There is 39% relative risk reduction in nephropathy, and you can see significant reduction in relevant renal events. Empiric outcome summary, as I said, it's a cardiovascular outcome trial. It showed that there is a 3-point MACE reduction, relative risk reduction by 14%, cardiovascular death 38%, hospitalized heart failure 35%, all cause of mortality 32%, and what we talk about today is the kidney outcome is 39%. So reduction was generally consistent across subgroup analysis. Empiric, as I said, it's a larger trial. They enrolled about 7,000 patients. They subdivided into 2 groups, and in all 3 groups, the kidney outcome with the progression to macroalbuminuria with relative risk reduction of 38% in empagliflozin and the doubling of creatinine 44% and initiation of renal replacement therapy with 55%. So add Jardiance to help reduce cardiorenal risk. You can start Jardiance because it's approved for us down to GFR of 30. And for patients with type 2 diabetes and cardiovascular disease, there is 35% relative risk reduction in hospitalization of heart failure, 39% in relative risk reduction in incident or worsening of nephropathy, and 38% in cardiovascular death, which is, of course, all significant. So evidence of SGLT2 inhibitors, a detailed look. We talk about empiric trial. There is another larger trial, a cardiovascular outcome trial called DECLARE. They used dapagliflozin in this study. Whether you have empagliflozin or dapagliflozin, in both it showed that there is reduction in MACE composite, cardiovascular mortality, hospitalized heart failure, renal composite. This all result was in favor of SGLT2 inhibitors, whether in empiric trial or DECLARE trial. So cardiovascular and renal outcomes with SGLT2 inhibitors versus GLP-1. I know everybody likes GLP-1 receptor agonist, and I'm sure you have lots of patients looking for Mounjaro and Ozempic. We don't say that they are bad, of course, but in terms of cardiovascular and renal outcome, with SGLT2 inhibitors in type 2 diabetic patient and chronic renal failure, you can see that in patients with type 2 diabetes and CKD, SGLT2 inhibitors were associated with a decreased risk of cardiovascular event and renal event, but GLP-1 receptor agonists were not. So SGLT2 inhibitors significantly decreased the risk of renal events. So as physicians, we always follow guidelines according to ADA and EASD consensus reports. Jardiance has established data in 4 pillars. You know what, we used to think before that when we treat diabetes, we go for a glycemic control only. Now there is a goals of care, so we have to go for glycemic management, weight management, cardiorenal protection, and cardiovascular risk factor management. And Jardiance has established data in all these 4 pillars of type 2 diabetes stated in ADA and EASD consensus report. So this is the EASD guidelines. Just to summarize it for you, algorithms, SGLT2 or GLP-1 receptor agonists can be considered as first-line treatment in patients with type 2 diabetes, plus heart failure or CKD with established cardiovascular disease or multiple risk factors for cardiovascular disease. The decision is to use whether GLP-1 receptor agonist or SGLT2 with a proven benefit should be independent of background use of metformin or baseline of HbA1c. SGLT2 inhibitors have now the same level of recommendation as a GLP-1 receptor agonist in patients with type 2 diabetes, plus atherosclerotic cardiovascular disease, indicators of high risk. SGLT2 inhibitors remain the only choice for the treatment of patients with type 2 diabetes plus heart failure. whether it's HFrEF or HFpEF, and the preferred choice over GLP-1 receptor agonist for patients with type 2 diabetes with CKD, as we have shown earlier, that even we can go up to less than 30 ml per minute. SGLT2 inhibitors are classified as high efficacy agent for glycemic management at the level, like it's the same level as exenatide, liraglutide, lixisenatide, metformin, sulfonylurea, or thiazolidinone, and above DPP-4. DPP-4 now is considered as intermediate. SGLT2 inhibitors are classified as intermediate efficacy agent for weight management. It's not a treatment of weight loss. Some patients, they come to us asking for them for weight loss. This is not a treatment. It's not for weight loss, but it will definitely cause weight loss because of secretion of glucose, which will lead to calorie loss. At same level as exenatide, above DPP-4 inhibitors. Thank you.